Well, good morning, folks. Just want to say we're going to wait just a couple minutes as we see the numbers of Zoom participants still going up, and we'll get started here shortly. So thank you all for joining us. Hey,
Thanks,
Bob.
Christine.
Good morning.
Hey, thank you. Good morning, Christine. Like, for some reason, my computer's not working, so I'm doing it on my phone.
Oh
So,
no. Oh gosh. Yes.
yeah, not
Zoom like the
ideal.
millennials.
And
Yep.
and
Zoom like
Dr.
the morning.
Almagan, I had that
Yeah.
issue too, so I think it might be a larger Zoom issue.
All right, now I'm getting it. Now I'm going to be in two places. Yeah, it's
Recording in progress.
got Christine and
Yes.
Dr. Levitt on. That's so everybody else can go home now. No, I'm just kidding. I'm teasing.
Ready to roll. Yes, ready to roll. Just going to give it a couple minutes. We see the uh, participant numbers continuing to go up. But if you want me to get started, boss, you let me know. Happy to get started. Everybody's here and slides have been checked, and I believe Eliza is ready to go.
Eliza, you ready to go?
Oh yeah.
You're not going to be doing morning report at the same time at Children's, are you?
I can try, but it might
Yeah,
be
you
hard.
might be welcome. Well, Christine, why don't you launch? This is great.
Sure. All right. Well, thank you all for joining us for our last installment of our Resident Research Symposium. It's always really exciting to see the new and innovative work that our residents are doing. It truly, I think, gives us hope for the future. And so we have an excellent lineup again today. We're going to start off, actually, our first speaker is Dr. Baird-Daniel, who came to us from the University of Colorado by way of Cornell, where she majored in neuroscience before medical school. And Eliza, I am biased. I'm excited. She has taken a keen interest in social determinants of health and penetrating traumatic brain injury. So she'll be telling us a little bit about that work today with her talk entitled Demographic Trends and Disparities in Craniocerebral Gunshot Injury. If you want to take it away, Eliza.
You can see this okay? Great.
Yeah, and there we go.
Awesome. So I'm Eliza. I'm one of the R4s, and I wanted to talk about one of the projects that I have been working on with the support of the Adler Grant and something that I hope to continue in my upcoming research year. So to offer a little bit of background on overall firearm injury, among developed countries, the United States continues to have the highest overall mortality due to firearm injury. This is unfortunately disproportionately carried as a burden by African American and Latinx communities. And concerningly, there's been actually an increase in overall firearm injury observed after the COVID-19 pandemic, with an associated increase in racial disparities. I have this figure here on the right, which is from kind of a landmark paper published in JAMA of this year, which shows that despite this overall downtrend in firearm injury from kind of the last 10 years, there has been this pretty significant spike following the COVID-19 pandemic in hospital admissions for firearm injury. So here's another figure. This is from a paper that I've been working on with Dr. Heather Barnett in the rehab department, but this shows that the patients that suffer firearm injuries are really demographically distinct from a lot of our other trauma patients. So namely, they're younger, they are less likely to be white and more likely to be Medicaid payers. So why is this relevant to us as neurosurgeons? Well, craniocerebral gunshot injury represents the most lethal form of both firearm injury and of traumatic brain injury. And I think that we've seen this anecdotally from our own practice at Harborview. The bulk of guidelines for treatment of these patients are based upon blunt traumatic injury. And it's really thought that not only are these patients physiologically or pathophysiologically distinct from the blunt injury group, but also they are likely to carry differing baseline population characteristics, as I sort of demonstrated above or in the prior slide. We have a very limited understanding, though, of kind of both how they differ pathophysiologically and how they differ on a demographic standpoint as well. So it's really critical to understand how these patients are different to better tailor care and to respond to what we're finding is truly a public health emergency. So my research is really motivated by that. So I'll start by talking about some of my hypotheses, specifically looking at some of these demographic and socioeconomic determinants of health and how they impact these patients and even how we sort of look at who these patients are. So I hypothesize that there is an increase in craniocerebral gunshot injury, or CGI, which is commensurate to the known increase in overall firearm injury. Similarly, I hypothesize that this change is disproportionately driven by patients of racial minority group, adolescent age, and lower socioeconomic status. And I also hypothesize that these same factors are predictive of worse functional outcomes, less access to neurosurgical intervention and rehab services and facilities. So in looking specifically at socioeconomic factors, I've used a subset of the reporting centers from the TQIP, or Trauma Quality Improvement Program National Database. This subset includes 128 of reporting centers. And what's special about this subset is that we have access to something called Distressed Community Index, or DCI, reported out. DCI is an index that serves as the most granular proxy for socioeconomic status that's available on a national level. It takes into account mean household income, poverty rate, level of education, unemployment, along with some other factors. So this, alongside with analysis of age group and race, are things that I was looking at as independent predictors of patient outcome and disposition after CGI. Some of the outcomes of interest that I'm starting to look at are disposition, as I mentioned, hospital/ICU length of stay, and hospital mortality and withdrawal of life-sustaining therapies. So to begin, as I mentioned, we're really not sure who these patients are, or like what are the distinct characteristics of this patient population. So here's a descriptive statistical analysis that kind of begins to address that question. So things I want to point out is I've separated these patients into intent, which is really consistent with a lot of the prior work. You can see that patients of prosperous and comfortable communities are significantly more likely to get to undergo self-inflicted injury, whereas patients of distressed communities are experiencing higher rates of assault, as well as unintentional injury. So again, this is really consistent with prior work, which demonstrates that assault is typically associated with higher poverty rates and unintentional injury associated with weaker gun law enforcement. You can kind of see this echoed again when separated by race, with patients of Black descent having higher rates of assault and those of white descent having higher rates of self-inflicted injury. So when comparing this to overall firearm injury, you can see that it's evident that this self-inflicted group within the CGI patients drives down kind of the rate of distressed community index as compared to overall firearm injury. And I think that's kind of an interesting separation between our cranial patients as opposed to kind of the general firearm injury cohort. So as I begin to look at outcomes, here is another descriptive table that shows disposition as separated by intent. As expected, differing outcomes are seen after these differing intents, which is reflected of the overall severity of injury, most likely. So self-inflicted injury being the most lethal, having the poorest hospital disposition, and unintentional injury being the least lethal, and those patients being most likely to go to rehab or to be discharged home. So what I'm working on right now is building a statistical model to explore the association of race and DCI on disposition when controlling for several factors, serving as proxies for severity of injury. Unfortunately, with this smaller subset of patients from the TQIP database, again, only 128 reporting centers that I was able to get DCI data from, it's a bit underpowered to look at some of my other outcomes of interest, including withdrawal of life-sustaining therapies and neurosurgical interventions and some of those other in-hospital outcomes. So I'll be using the whole TQIP database to look at those kind of at the sacrifice of DCI, using likely payer status to examine those. I'll also be using the entirety of the TQIP database to look at trends over time. So I hope that this work can aid in identification of communities or of community and legislative interventions that are effective in ameliorating the influence of environmental factors on brain injury and outcome. And I think this will really complement some of my other work, which is looking at how CGI has distinct pathophysiology as compared to blunt injury. So I've been really lucky to have access to truly incredible mentors within the UW system, both within our department. You can see Dr. Bono, Buckley, Robin Pay, Mike Myers, and then also kind of in a interdisciplinary standpoint with real experts in the field of gun violence nationally, Dr. Ali Rawani Rabar, Dr. Heather Barnett, Dr. Rivara, and Dr. Walster offering her support as well. Great.
Really nicely done, Eliza. Any questions from the virtual crowd? I just had one I was going to ask you about, which was, as you look at this data, have you thought about considering differences in provider interaction? This has come up before with just questions about how people communicate to patients. Any insights from your initial kind of literature search around potential biases or themes and trends and how the family, the patient themselves may even subconsciously change how people communicate for you as a rising neurosurgeon yourself? So thinking from the standpoint of the provider.
Yeah, I think that's a really interesting question. For one, this population obviously has a higher burden of like self-inflicted injury. So these patients, just by nature of that, don't quite get access to some of the same resources that overall firearm injury patients do get. So I think that really changes the communication amongst them, given that they are typically more skewed towards psychiatric services as opposed to rehabilitation services. And then another interesting thing that I'll be looking at, as I mentioned, withdrawal of life-sustaining therapies. And that's something that other work has shown has a lot of like cultural implications. And so I think a better understanding of how patients of differing demographic backgrounds kind of either do or do not pursue those things in the setting of really severe injury will be really interesting.
Yeah, and even just the recommendation to also look by site. There is
Yes.
some selectivity in where you trained and where you work on
Yes.
how much that is advised, even in more aggressive or less aggressive standpoints. Excellent, excellent. Okay. Any other questions, comments from the crowd? All right, hearing none, we'll take you off the hot seat. Thank you so much, Eliza. That was a great presentation.
Thank you.
Up next, we have Dr. Kate Carroll. Oh, there she is. Thank you, Dr. Carroll. She will be leaving us this year, graduating her program, heading off to pursue a fellowship in pediatric neurosurgery. After spending medical school at UCSD and residency here with us on the West Coast, she'll be heading out to the East Coast. Kate today will be providing us with an update on her work focused on the role of CRHR1 genotype and HPA axis dysfunction in depression after aneurysm rupture. Kate, the floor is yours.
Hi, everybody. Thank you. It has been a privilege to get to work on this for the past couple of years. I think everybody has heard and seen a lot of these slides a couple times before, so I'll try to go through the intro a little bit more quickly. But this is going to be about the work that I've done looking at depression after subarachnoid hemorrhage and its relationship to the HPA axis under the supervision of Dr. Levitt, Dr. Visse, and Dr. Dubovsky. So again, just as some background, mental health and depression after subarachnoid hemorrhage has become kind of a focus as patients are living longer and doing better in recovery. We are now thinking more and more about what recovery looks like and what that means. And so this meta-analysis in the Journal of Stroke showed that patients after subarachnoid hemorrhage have about a 30% pooled risk of new onset depression. And this is typically mild to moderate. Risk factors include a prior history of a psychiatric diagnosis as well as spontaneous aneurysmal subarachnoid hemorrhage, but no association was noted with age, functional deficit or outcome, and treatment type. And so there has been some previous work into kind of what specifically makes people at risk within the aneurysm population for depression. And this was a retrospective study, which was kind of the motivation for some of my research, looking at genetic risk factors. So this was a retrospective cohort study done in England. They looked at all surgically treated ruptured aneurysmal subarachnoid hemorrhage patients who presented over the course of about a decade. They identified 125 eligible patients and then retrospectively contacted them, performed an emotional state questionnaire, and collected venous blood for genotyping. And what they found across two different studies looking at both mental health outcomes and quality of life is that the higher penetrance of minor alleles of certain SNPs were associated with better outcomes on both quality of life and depression scales. So closer you were to homozygous for the minor allele, the happier and better quality of life you had. Granted, not all of these were significant. These were kind of like trends in the direction, with one or two of the results being significant. Still, it is worth investigating. And so why do we think that is? The hypothesis is that prolonged stress results in HPA axis dysregulation. That dysregulation ultimately results in structural changes in the brain that are then associated with depression. Advance. There we go. So you have this upsurge in glucocorticoid and cortisol production. The receptors get desensitized. That leads to more CRH being produced, more GCs. So it's this kind of circular loop. This is supported by findings within depression population at widely of elevated CRH levels in the CSF. They respond abnormally to low-dose dexamethasone suppression tests, and their responses normalize if they are then adequately treated. We've also seen in pathology studies that there is decreased CRHR1 expression in the anterior forebrain in patients with depression. And across multiple patient populations now, there is work that has been done showing that the polymorphism, your specific genotype for CRHR1 receptors, is associated with risk of depression. This has been replicated in hurricane survivors, so kind of psychiatric stress survivors, people with PTSD, in patients who had medical or surgical ICU stays, and then in our patient population, the aneurysmal subarachnoid hemorrhage patient population as well. And putting this all together, this is kind of what the model looks like. This comes from ischemic post-stroke depression literature, in which this is a very well-known and studied phenomenon. The idea being that you have a stroke that results in stress on the body, activating the HPA axis, prolonged elevated levels of CRH results in reduced brain-derived neurotrophic transcription, which then ultimately winds up in some structural changes that are associated with depression, such as changes in the anterior cingulate, orbitofrontal gyrus, hippocampus. These are all places that where CRHR1 is expressed. We see changes on this in MRI, and so this is thought to kind of result in the overall milieu that then predisposes these patients to depression. And so what we've been doing for the past 2 years is a single institution observational cohort study. Our goal was initially to recruit 30 patients, it was initially to recruit 50 patients. That has fallen, and now it's actually going to be 28 based on our assay, the Eliza test that we run. These are our inclusion criteria. We excluded non-aneurysmal subarachnoid hemorrhage patients, as well as infectious or traumatic aneurysms. And the basic study, or the basic structure of the study was during their acute hospitalization, we collect blood and CSF samples at specified time points. Those were processed and frozen for storage. They are getting sent for CRHR1 genotyping, as well as BDNF and CRH levels in the CSF and serum. And then in follow-up, we contact these patients at 6 weeks, 6 months, and 12 months and perform a PHQ-9 depression assessment, as well as send them a packet for salivary cortisol collection. And so as an update about where we are now, we have screened 140 aneurysmal subarachnoid hemorrhage patients. About half of those were excluded due to not meeting inclusion criteria. 79 patients were eligible, 9 declined when approached for participation. And in 44, we missed the presentation window. And I think that this is obviously the spot where we could do better, if better resourced. But we've enrolled 25 patients now, and this is over the course of about a year and a half. There is nothing surprising about our demographics of those we've enrolled. This is just an update. And then in terms of mental health outcomes for those that we've seen so far, these patients typically have a mild depression and mild anxiety. And I will say we don't have the numbers to kind of say this with any certainty. The last time that I presented this with half the numbers, the trend was increasing over time. This time it's decreasing over time. So I think the more interesting thing is going to be how individual patients' hormone levels and SNP then associate with their mental health outcomes. But this is the overall trend. And so since this is the last time that I'll be discussing this research and I'm on the tail end of this, I just wanted to discuss a couple things in my last 30 seconds for those people who are looking into their research here. If I could give myself advice about how to do this, it would be the following. Only introduce one new element. For me, this was a lot of new things. And while my background in research was like epidemiology, clinical trial, translational stuff, and like design, as well as psychology, I did not have the wet lab skills under my skill set. So I think a lot of my effort went into finding people who could help me do that, learning how to do that, trying to troubleshoot how to do that without having the expertise that made that easy. So I think just being like really honest with your skills and like with what you are going to be able to accomplish within residency with the limited time that we have available to do this will allow you to like present at this point a finished product, which I think is great. Mentorship is crucial. Dr. Levitt is an extraordinary mentor and has a very efficient research lab. My project, however, was outside the scope of any of our expertise. And so I had to really like search for people who could kind of provide that next level expertise on how to do all these assays and like what to even think about. Planning ahead of time, I think just like making as detailed as possible an outline of what this is going to look like can be really helpful. And then since you have to come back and forth from the research a lot between clinical and research obligations, just take the most copious notes so that you know where you are in your research at any given time. Document all of the emails that you sent with people, document why all decisions were made, so that you have a really easy reference anytime you want to come back to it. And then in sum, I do really hope that this is going to kind of finish. We are on the tail end of defining our assays, and some of this is in production and some of it is about to actually result. So in a year, I would have a whole new set of data to show you guys, but hopefully you can read about it in the future. And I'll just acknowledge all of my mentors, the people who helped push this forward. And yeah.
Really nice talk, Kate. And to end on the note of reflection, I think is wonderful. And hopefully the juniors in particular and the interns in particular are listening, because points well taken. Yeah. But it still was an extraordinary project, and it could be something that could be turned into a lifelong research program if the time was there. But you're right. Time is precious. Any questions, comments from the crowd? Maybe we put Dr. Levitt in the hot seat. Mike, any thoughts in reflecting back on a successful mentee?
I think Kate did a great job, and I think the the one thing to note is that this stuff is hard,
Yeah.
but you're essentially inventing an intersection of three fields, which is why this is hard, right? So it's neurosurgery, mental health, and endocrinology. So this is like a triple problem. I think the stuff that we sort of discovered together and learned can be applied to, it doesn't have to be any vascular neurosurgery, it could be anything. You know, this concept of SNPs leading to greater susceptibility to stress-induced mental health events is not unique to any specific disease process, but the study of how those endocrine factors get deranged and influence that could be applied to a pediatric population, for instance. So, you know, I think that there's opportunities to continue this line of research with the skills that you've learned, and I'm going to hold you to that because you're an R25 recipient. So
No, that is certainly the goal. And in addition to the R25, I just wanted to take the opportunity to also thank Dr. Ojiman and Linda Ojiman for their support of the project. It has been absolutely crucial to have funding that has allowed this to continue, because it would not have without it.
And that's a good plug for the George and Linda Ojiman Innovation Fund, which is available to residents who are in the process of completing their research year and need follow-on funding to keep their research going when they return to clinical service. This is a key resource that is specific to our department, and it's really great. And it allowed Kate to fund this work even when she was on her R6 and R7 rotations. So I also want to thank the Ojimans senior and junior for their vision, and just recommend that residents who are doing their research here think about that as follow-on funding. Thank you, Kate.
Thanks.
Yeah, excellent work. Excellent work. Okay. Well, with that, we will flip from the very end to the very beginning. We'll go back, and up next is Keanu Chee, another U Colorado grad, just like Eliza, who joined our residency program this past year. And, you know, as I was joking with him, the eyes are still open. He's still here, almost through intern year. Keanu is going to be telling us about work he's done focused on piriform cortex atrophy and how it's discordant with seizure lateralization and temporal lobe epilepsy. So Keanu, do you want to take it away?
Yes. Hi, everyone. My name is Keanu. I'm one of the neurosurgery interns, for those who I haven't met. And this was some work that I worked on during a research year at the University of Colorado as a med student, which is now coming to fruition as we finish up the paper. But this project is entitled Piriform Cortex Atrophy is Discordant with Seizure Lateralization in Temporal Lobe Epilepsy. So temporal lobe epilepsy, or as I'll refer to it just for time's sake, as TLE, is the most common form of focal epilepsy, and it primarily affects brain regions that are critical for memory, language, and executive function, which explains many of the cognitive symptoms that these patients experience. About 1/3 of TLE cases are considered medically refractory, meaning they don't respond adequately to anti-seizure medications. And so these patients often become candidates for surgical resection. And these traditional targets have included things like the hippocampus, the amygdala, and the parahippocampal gyrus, to name a few. But despite resecting these mesiotemporal structures, whether it's targeted resection or anterior lobectomy, temporal lobectomies, even up to 40% of patients will still continue to have surgeries or seizures after surgery. And that kind of highlights the need to better understand additional epileptogenic regions. And this brings us to the piriform cortex, or as I'll refer to as the PC, which is an emerging area of interest in temporal lobe epilepsy. It does represent the primary component of the olfactory network. And the reason that we initially became interested in the piriform is because of the classically described seizure aura, which is the smell of a burning tire. And I think that was the initial reason that the PC became implicated in temporal lobe epilepsy as a key seizure hub. Several studies have shown that resection of the piriform have resulted in higher odds of achieving seizure freedom in surgical candidates, which I'll get to a little bit later. But despite this, the piriform still remains an undersampled region in intracranial EEG studies and has not been extensively explored in human clinical settings as well. And so I think there's a growing interest in better understanding the piriform, not just as a passive participant in seizures, but also as a potential driver in epileptic activity, particularly in temporal lobe epilepsy patients. So the piriform, like I said, is a major part of the primary olfactory cortex and is increasingly becoming recognized as a possible seizure focus in temporal lobe epilepsy. It does have both a frontal and temporal component and wraps around the MCA within the sulcus there, as you can see in the bottom left. And in animal models, the piriform has shown, and these are like animal epilepsy models using the kindling model, does show an increased excitability, reduced GABAergic inhibition, and the piriform does show a hyperexcitable state during epileptogenesis. Animal studies have also shown that ablating this region significantly reduces seizure spread, which supports its role as a possible site of seizure propagation. Architecturally, it does have a tri-layered structure that is very similar to the hippocampus, which could explain its vulnerability to seizures. And also, unlike other sensory systems, the olfactory pathway actually does bypass the thalamus and does not undergo primary regulation. And so this could possibly enhance its ability to transmit seizure activity. MR studies have shown consistent volume loss in the piriform in temporal lobe epilepsy patients, which may lower the seizure threshold. And importantly, there have been 2 studies in 2019 and 2020 that did show that resecting over 50% of the piriform cortex actually increases the odds of achieving seizure freedom by 16 times, which certainly highlights its key role in epileptogenesis. And so this led me to ask the question, is piriform atrophy, is this a unique phenomenon seen in temporal lobe epilepsy, or can this also be seen in non-temporal lobe epilepsy? And in unilateral temporal TLE patients, does this lateralize to the side of seizure focus? And really the intent was to determine whether or not piriform atrophy could be used as a biomarker for predicting seizure severity and possibly lateralization in temporal lobe epilepsy patients. So the objective of my study was to utilize a robust volumetric analysis to determine whether piriform atrophy occurs strictly in TLE patients or also non-TLE patients. And to determine the pattern of piriform atrophy to see if it localizes to the side of seizure focus. And I hypothesized that piriform atrophy is unique to temporal lobe epilepsy and that the atrophy will primarily be seen on the side ipsilateral to the seizure focus. And so we conducted a single center retrospective cohort study at the University of Colorado from 2013 to 2023. We included adult patients over the age of 18 who had either temporal lobe epilepsy or non-temporal lobe epilepsy. For eligibility criteria, they had to have medically refractory epilepsy. Second, they had to have a well-defined unilateral seizure focus confirmed by phase 2 steroid EEG monitoring in our EMU. And third, they had to have high-quality T1-weighted MRI scans that would allow for detailed volumetric analysis. And we excluded patients whose seizures were attributed to identifiable structural causes such as tumors, vascular malformations, cortical dysplasia, or those with multifocal or generalized epilepsy. And for control, we used a healthy adult volunteer data set from the NIH called the Open Neuro data set, and that provided standardized high-resolution T1-weighted MRIs for comparison. Manual piriform volumetric analyses and segmentations were performed by 2 blinded raters. They were both trained on separate control data sets from the 20 that were included in this analysis. And that data set was also used to determine intra and inter-rater reliability. These tracings were done using well-established neuroimaging landmark-based protocol from 3 studies, as opposed to the manual segmentations for the piriform. The hippocampus and amygdala volumes were automatically segmented using a automated process in VolBrains, which is a free online resource that will do the segmentations for us. And then we adjusted our volumes for both age and total intracranial volume so that we could standardize values across subjects. And to do our comparisons, we did simple t-tests to control volumes or to compare volumes. And so moving into the results, overall, our study included 20 control subjects, 35 patients with unilateral temporal lobe epilepsy, unfortunately only 13 with non-temporal lobe epilepsy for a total of 68 patients in this analysis. And then for the volumes that you can see here, these are the raw and unadjusted volumes. And I think the most important thing to take away here is that in control subjects, we can see that the right piriform is significantly larger than the left. And so we did, when we corrected it or adjusted the volumes for both total intracranial volume and age, it still, again, demonstrates that the right piriform is bigger than the left in controls, but the difference was then not statistically significant. So this is a super busy slide, but I'll just kind of go through the most important parts. And so what I want to really point out is the piriform volumes. And looking at the numbers in green, these are analyzed as percent change, or like volume reduction calculated as percent change in comparison to controls. And when we look at left piriform volumes between controls and disease subjects, we see that there's a 15% decrease in the left piriform volume in left TLE patients. There's a 29% decrease in left piriform volume in right-sided TLE patients, and a 20% decrease in patients in the left piriform in patients with non-temporal lobe epilepsy. Then we go to the other side and we look at the right piriform volumes between controls and disease subjects. We see a similar trend where there's a 17% decrease in the right piriform in left TLE patients, a 29% decrease in right piriform volumes in right TLE patients, and a 23% decrease in the right piriform in non-TLE patients. And all of these percent changes, or these decreased volumes, were statistically significant. And in fact, when you actually go through the whole table, I did highlight just the piriforms, but even for the amygdala and the hippocampus, almost all of the studied areas demonstrated statistically significant reduction in volume, except for the left hippocampus in right temporal lobe epilepsy patients. But again, I think an important observation is that across all areas, the piriform consistently demonstrated the greatest percent change and volume reduction in comparison to the hippocampus and the amygdala. And lastly, we looked at whether the volumes for all the areas, when we adjusted for age and total intracranial volume, whether that had any correlation with duration of disease. And for all three, the piriform, amygdala, and hippocampus, there was no significant correlation with disease duration. And so in conclusion, in this study, we compared volumetric data across three key brain regions: the piriform, the hippocampus, and the amygdala. And we found that there were significant volume reductions in all three regions in both TLE and non-TLE patients when compared to controls. But the most striking finding was in the piriform, where we observed the largest volume difference here, about 20% reduction bilaterally compared to controls. But importantly, opposed to what I had hypothesized, this volume did not lateralize to the side of seizure focus. There was no correlation with epilepsy duration. So to me, this suggests that the piriform atrophy is likely an early and bilateral process in focal epilepsy patients, rather than a result of chronic seizure activity over time. And it is unlikely to be a useful biomarker in predicting seizure severity or the lateralization of seizure focus. And in the interest of time, I'll just move to my acknowledgement slide. This is the team I had worked with as a medical student, and I'm open for questions.
Thanks, Keanu. That was great. Any questions out there?
Yeah. Can you hear me?
Yeah.
Is that Andrew? Hey.
Yeah. Hi.
Hey, Andrew. Oh, Dr. Ko is there. All right.
Yeah, Andrew's fine. Hey, Keanu, what do you think would you, I guess, what would you think of as the next things to look at with respect to this? I mean, if you're saying that there's some involvement, but not a sort of straightforward correlation of volume, tissue volume, do you have something that you think might be interesting to look at next?
Yeah, so I think that like looking at EEG recordings of it to determine whether or not seizure activity originates from there, or whether it's like an innocent bystander, would be really interesting. When I had studied kind of the connections of the piriform, it's connected to really a lot of different areas, as well as the contralateral piriform. And so what I had hypothesized that maybe seizures don't originate there, but because it doesn't undergo regulation by the thalamus, it serves as a very accessible highway for seizure activity to propagate. And so I think a big thing that I wanted to look at was, one, can we kind of hone in on better margins and come up with like a automated segmentation process, a reliable process, to then see like, are we commonly including this in our resection margins? And if it's being left out, then trying to expand on that and see if we include more of it, like those two previous studies had showed, are we achieving higher rates of seizure freedom in patients with medically refractory epilepsy?
Okay, great. I think at least one person on here is very good at segmentation. Have you talked to Christine, Dr. McDonald, about this?
We have a whole team of experts. We have your people call my people, Keanu. We have a whole team of experts that can potentially help you if you want to expand that here.
Yeah, that'd be really cool.
Yeah. All
Yeah, and
right.
obviously
Well,
talk to Ben and I about it too.
Yeah,
yeah.
absolutely.
Excellent. Okay. Well, in the interest of time, we will move on. Up next, we have Dr. Julian Clarke, who, like many of us, surprising number of us, traded WashU for UWash over the years. And he's also starting to rival the most accomplished Dr. McAvoy for the number of both Julian and Melissa. Today, he'll be telling us about work that he's been doing in understanding the role of brain capillary parasites.
Good morning. Can you guys hear me? All right. So my talk is on the role of brain capillary parasites in DCI after aneurysmal subretinal hemorrhage, which is some work that I've been doing for a couple of years now with Dr. Levitt, Dr. Chee. Just to give an idea of the framework that I'm working within. So aneurysm rupture splits off into two main injurious pathways: initial brain injury, something that we all see, subretinal hemorrhage, global ischemia. But the secondary brain injury pathway, which we see a lot of in our ICU setting, is split into early brain injury and DCI. I'm focusing specifically on the microvascular thrombi formation after aneurysm rupture. Looking at the importance of this, I mean, in our last AHA-ASA guidelines for the management of aneurysm subretinal hemorrhage, 3 out of the top 10 main take-home points in the guidelines revolve around delayed cerebral ischemia. So obviously something that we as a field are working tirelessly to try to determine better treatment pathways and improve outcomes for. Other background that's important here. So what are parasites, right? So parasites are these small contractile cells that are kind of mesh-like and finger-like that line the cerebral microvasculature at the arteriolar capillary junction, as well as capillaries themselves. They are major regulators of cerebral blood flow. So as they contract, they actually constrict the capillary network itself and impair microcirculatory perfusion, reduce cerebral blood flow. And it has also been shown that relaxation of parasites subsequently dilates these capillary networks. And then as far as microvascular thrombosis, so there are microclots that form after experimental subretinal hemorrhage across multiple induction techniques, multiple animal models, and also observed in human studies. They're shown to be independently associated with neurological deficits after aneurysm rupture in mouse models, as well as rat models and rabbit models. And so this body of evidence combined strongly in favor of further investigating the mechanism behind the formation of microvascular thrombi and able to visualize them in real time. So my aims, I'm going to look first at measuring the effect of pharmacologic therapy on the relaxation of parasites, and then separating the experiment to examine and visualize the response of parasites to subretinal hemorrhage. For my first aim, we have designed a mouse model that specifically targets capillary parasites in the central nervous system. They express DREAD target signaling or G protein coupled receptor pathways that specifically target capillary parasites in the central nervous system, allowing for chemogenic manipulation of the capillaries and not at the smooth muscle cells of the arterioles. So what this diagram here is over on the right is a better way to visualize this process, but essentially here on the left, this first one is a capillary network. And these little bright dots here are parasite territory surrounding this capillary network. This line scan in the middle here is what our parasite or what our capillary networks look like. And this is under a 2-photon microscope through a cranial window in a mouse. DCZ is our selective agonist for GQ-DREAD, which is our driver for contraction of capillary parasites. Injection of DCZ, you can see here in real time the constriction that we see in the capillary network due to contraction of parasites, essentially clamping down on the cerebral vasculature, the microvasculature, And what this is essentially provides a platform for pharmacologic intervention. Down here on the second diagram, you can see that the flux, which is the cells per second that are flowing through the capillary network in parasites that are covered by GQ dread that can subsequently be constricted by DCZ. The 15-minute decrease in flux is significant in comparison to the parasites or the capillaries that are not being ensheathed by parasites targeted with GQ dread. So what this does is provides a test bed for pharmacotherapeutic intervention to try to relax parasites. And so why is this important? My hypothesis is that these parasites, which are surrounding vessel endothelial cells, specifically capillaries, are affected by aneurysm rupture. Subarachnoid hemorrhage happens, there's blood-brain barrier breakdown, there's global cerebral ischemia. It's known in the literature that parasites constrict and die in response to ischemia. And so this is where my first aim is starting to take a look, is a specific test bed with a particular pharmacotherapeutic intervention that allows for prevention and or attenuation of the parasite constriction and death response prior to subsequent formation of microvascular thrombi. And what I think is happening is that the constriction in the microvasculature leads to a static and prothrombotic environment with reduced blood-brain barrier integrity, increased inflammation, increased leukocyte adhesion, decreased circulatory blood flow. All of this leads to increased platelet aggregation and subsequent thrombus formation. So this is the test bed that I'll be working off for my first aim, and I'll be using to start Fasudil, which is a Rho kinase inhibitor and a vasodilating agent that increases endothelial nitric oxide synthase. The reason being Rho kinase is vasoconstricting protein that moves on the cytoskeleton through the myosin light chain. And this has been shown to be one of the main drivers of parasite contraction. Additionally, there are prior studies that show that Fasudil, which is this inhibiting medication, can attenuate capillary constriction. This is in different studies that use optogenetics rather than chemogenetics in order to contract the capillaries themselves. But my hypothesis is that this will hopefully relax the parasites and show that there is possible for or potential for intervention at this time point prior to formation of microvascular thrombi. My second name, so the second arm of this experiment will be taking these mice and actually inducing a very small volume subarachnoid hemorrhage using a laser to cause a peel vessel rupture and release blood into the subarachnoid space. Looking at the capillary zone itself under the microscope and watching this happen in real time, you can actually see these this blood is labeled fluorescently. You can see the area of leakage when vessel injury is caused by the laser. Can then look at the capillaries in the surrounding area, look at the parasites in the surrounding area, and watch to see both temporally and spatially in response to the area of subarachnoid blood where the constriction happens. And so by proving that constriction happens after subarachnoid hemorrhage and location and time course both can be understood after watching that happen in real time. Combining that with the first aim and looking at the ability of pharmacologic attenuation or reversal of constriction, my plan is to combine those two into a larger experiment down the road. So I could take these to hopefully get some good data from it and then combine it into a larger mouse model study using aneurysmal mouse models that are larger scale endovascular perforation or prechiasmatic injection models and testing for neurologic outcome in larger animal models. Additionally, something to note, there's some interesting human studies down the road that I'm curious about as well, but running out of time. So I'm happy to talk about those more offline. Just wanted to thank Dr. Chee, who's my primary PhD mentor on this project, and Dr. Levitt, who, as you guys know, we're spending a lot of time together working on this. And then, as always, thank Dr. Ellenbogen for all of his support. Questions?
Well, it's an excellent talk, Julian. And possibilities of 5 R01s underneath that work. I want to ask a quick one as it pertains to parasite and aging, and parasite remodeling, because the patients, it's who, right, that you see as the neurosurgeon. It seems like they tend to be a bit older, and then when you consider the literature, just pulling from the aging side of parasite remodeling. Going down a bit is my understanding, limited, I know, of when you get older. Is there a consideration of doing this, but also thinking about it in an aged model? If that's really a large portion of the patient population, if you want a therapeutic target that's going to work, the slower process of that ability to remodel, and the more likely to have that capillary dilation when you're older, how does that play into the considerations here?
It's a good question. I'd say it's not something that I've thought about in detail, mostly because I'm looking at the acute response to parasite injury, like how parasites are injured, and essentially in the stroke literature, parasites die with ischemia. They either are permanently injured or they die. And so I've been looking more at just what that response is going to look like after aneurysm rupture in an acute time frame, right? Like 15, 30 minutes, 1 hour after inducing subarachnoid hemorrhage. I think longer term, it's another, like you're saying, is another avenue that this could take, and looking at the differences in parasite response and looking at the differences in like regulation of the microvasculature in somebody who's in their 30s with an aneurysm rupture versus in their 50s versus in their 70s. So interesting avenue, but not something that I've really explored with this experiment itself.
All right, fine. Make it your second or third R01 then. But down the line, right? Like the point is that they're probably at a different baseline milieu than your 30-year-old patient. I see Christoph's got his hand up. Dr. Hofstetter, questions, comments?
Hey, Julian, nice talk. Interesting topic. 2 questions I have for you. The Rasodil, how specific is it? Because, rho kinases are involved in cell motility, division, they have a lot of functions. And so the question is, if you result with your experiments, how specific is it going to be? And second question, what time frame of the subarachnoid hemorrhage are you targeting? Immediately, or is there a time window that you're looking at? So specificity and timing.
Yeah, great question. So the first regarding Fasodil, there are going to be, so the specificity with this experiment does not come from the pharmacotherapeutic intervention. It comes specifically from the chemogenetic targeting. So by targeting central nervous system parasites only, we'll be able to see the effect that Fasodil has on those central nervous system parasites. One of the considerations is that a systemic effect of Fasodil is that it's a vasodilator. It's used in pulmonary hypertension as well. And so I have to mitigate the side effects of that. And so I'll be using a few different doses to see globally if there's other issues with that, rather just, because hypotension is obviously a side effect that we do not want carrying over into our subarachnoid hemorrhage population. The second question, in regards to, sorry, remind me of your second question again.
No, the timing,
Timing.
what do you think is it?
Yeah, so right now, the plan is to just immediately, like in real time, see the response to parasites as subarachnoid hemorrhage is occurring. So as blood product is leaking into the subarachnoid space, just to prove mechanistically that this is occurring, the next step would be to have a animal model that is a larger scale endovascular perforation or prechiasmatic, something that is a full subarachnoid hemorrhage model. Those animals, there's lower throughput, 2 or 3 of every 10 mice die in those types of experiments. But to use that as a test bed for time frame and see when neurologic outcome is affected specifically by microvascular thrombi, and administer the pharmacotherapy intervention at various time points. So that won't be as much for this time and this year, but moving forward to the next steps for animal model experiments would have to have a larger time course experiment with multiple days after aneurysm rupture, assessing behavior, assessing movement, assessing imaging characteristics, but that will come down the road.
Well, a lot of excellent foundational work you're doing, Julian. I think that's the bottom line. It's really, really terrific, really innovative. Okay, I think in the interest of time, we'll need to move on. We're next going to hear from Dr. James Pan. James, like Kate, is flying the coop soon, heading back to Stanford, where he did his medical school as well. And one of his last presentations to us today, he'll be telling us about his work in large language models for generating patient-friendly after-visit summaries. So over to the good Dr. Pan.
All right, thank you, Dr. McDonald, for that introduction. So I'll be talking about just that, using large language models for patient-friendly after-visit summaries. So last week you heard from Dr. Chotova on some of the work that we've been doing with operative reports, where we used AI to simplify operative reports so that patients can better understand them. This next evolution of this project is naturally to work on something bigger in bigger scope, and that is clinic notes. Often, when the patient opens their chart and reads the notes, the original note written by the doctor, which might not capture all the information or define it in a way that the patient can best understand it in. So I'm wondering, can we do a better job of that? Can the patient understand their care a little bit better so that they can be more empowered to take control of their care, better care coordination, allow them to share their diagnosis and plans with friends and family, and so forth. So the nice thing is, so this was actually modeled after a study that was done by a group at NYU, where they used large language models to write patient-friendly inpatient discharge summaries. So we write discharge summaries all the time for patients that leave the hospital, and they found a way to use AI to generate versions of that that are in a more patient-friendly format. So what's nice about the after visit clinic summary is that's actually a well-defined document by CMS, where an after visit summary is a pretty standardized document where it improves the patient's ability to recall care team interactions and share them with friends and family when necessary. It encourages the patients to adopt healthy behaviors and self-manage chronic conditions, and improves EHR data handling, as it enables patients to review records and potentially identify any errors in their care. There are elements of an after visit summary that have standardized elements, things like identifiers, what the provider told you, vitals, diagnoses, any orders that were placed, any test results that were discussed, medication list, allergies, problem list, chronic conditions, and any necessary health maintenance steps. So the way we designed this study was we took a bunch of clinic notes, people that was seen in the neurosurgery outpatient clinic. We developed a prompt to help distill the clinic note written by the doctor and also data from the EHR into a large language model, created simplified versions, and then verified them for safety and accuracy. So if we look at all the clinic visits that our department has conducted since January 1st, 2023, and this is just new visits, we did over 10,000, so that's quite a feat. We selected 200 records for feasibility, and based on prior numbers that were done by prior groups, that JAMA study that I mentioned looked at 50 inpatient discharge summaries. We selected 200 records that were representative of our type of practice for analysis and large language model processing. So about half spine, half cranial, and a little bit of peripheral nerve sprinkled in. You can see here's the representation of the type of disorders or diagnoses for the cranial patients, the spine patients. As you can see, there's an underrepresentation of some of the issues that we see on an inpatient basis, like there's not many trauma patients, not many infection patients, since we're only looking at diagnoses discussed during new patient clinic consultations. You can look at the attending physician distribution below, which shows that there's no dominant author of these kinds of notes. So, so the input that we put into this model is a wide representation of all sorts of authors writing these kind of notes. So we want it to be generalizable as well. So the way we developed the prompt was we did some initial prompt drafting, basically told the element here, write a after visit summary that has all these elements, that does X, Y, Z, and within all your specifications. We iterated upon that process, tested it on a few clinic notes. We did some pilot testing where we asked a medical student to review some initial outputs, went back, refined it until we finally got consistent outputs that we were happy with. And then we came up with our final prompt, which we then ran on 200 of those records that we selected. So this is kind of a video of how this works. So this is kind of like a back end AI designer, and then on the right is a real clinic note de-identify that was written by Dr. Shaker about an aneurysm. So what you do is just copy that clinic note into this AI backend, and then it's now processing it, and you can see then it spits out exactly a perfectly formatted after visit summary written at a level that a patient can understand, contains all the pertinent information and the elements that CMS has identified. Also included some other extra things like a glossary to define some clinical terms that I think the patient will find very, very helpful. So you can kind of see that over there. So the next step in this, and this is what we're currently working on, is doing verification and assessments. We've generated all the simplified clinic notes and have the original clinic notes. We'll do some linguistic analysis on it, analyze the readability, complexity, word count, and semantic similarity of the AI simplified versions. Verify for completeness, does it contain all the elements that CMS prescribed. We'll also assess the actionability and understandability of the simplified notes versus the original notes using a battery called a PMAT assessment, again, which was what the authors of that prior study used. And we'll also have individual physicians rate the trustworthiness. Basically, is it accurate? Are there any safety issues? And what is the hallucination rate, meaning that is the AI model kind of just spitting out nonsense, which I think should be pretty low, because I think AI as it is right now is very good at translating from X to Y. I don't think it's very good at making independent thought, independent diagnoses, telling it to write like a profound novel or something like that. I don't think it's so great at that. But if you have a given input within a narrow scope of what you want it to do, I think it does a very good job of that. That's where we are right now. I think we're looking for more collaborators. So please send me an email if you're interested in bringing this project to the end. I think it's very interesting because it has very wide uses beyond neurosurgery. So I think this is potential for lots of impact, potential commercial applications, so money if you're interested in that. So please send me a message if you're interested in getting in touch. Now, before I finish, I just want to let you guys know one more thing. That demo I showed you prior to, which kind of showed a live transcribing one of Dr. Shaker's notes, you can actually, I actually have a live version of this. If you scan this QR code with your phone or just go to this website called uwclinicdemo.azurewebsites.net, you can actually interact with a live front end version of this where you can copy and paste your own clinic notes into a little box, and then it'll spit out an after visit summary just for you. It's hosted on a secure UW instance of Azure OpenAI. So all the backend processing is done at the UW. It's protected behind a UW NetID authentication, so it's relatively secure. And if you do use it, please don't put PHI in there, as you know. So just try it out with your real clinic notes, give the summaries to your patients, of course, read it and make sure that it makes sense, and put it through its paces, and send me some feedback. And I'd love to hear what you guys do with it and what you guys think.
Awesome, James. Thanks so much. I see Randy's got his hand up. Over to Dr. Chestnut.
Yeah. Hi, James. That's very interesting use of AI. And very useful. But a bit of two questions. One, how do you define understandability and comprehension given the variables on the receiver end of this medical jargon and maybe imperfect communication skills on the part of the physician? So how do you know that this is understandable to a patient and contains what they need to know? And the second question is could this kind of thing be adapted to training physicians in communication skills outside of just note writing, but actually sort of a real-time interaction with patients so they stop doctor talking and losing people?
Yeah, I think that so I'll start with the second question first. I think, like I said, I think AI right now, the way that it works, I think it's really great at translating stuff. Like, you want to, let's say, I want to simplify, I want to rewrite this at a 6th grade level. I rewrite my, thoughts, in a form of a Shakespearean poem. Like, I think it does a really good job of that. So I think it can really improve or adapt the way that we communicate to people with different communication preferences. So I think this is tremendous potential for that. And the first part of your question on how we know if it's more understandable or actionable, that's what the PMAT instrument is for. It's a standardized battery of, I think, 25 or so questions. All binary questions, yes, no questions, like, is it easy to read? Like, does it make its purpose evident? Are there visual aids? Are things like yes and no? So then you get a score at the end, and then we're going to compare the score on the original note versus that of the AI simplified note, and kind of get an effect size and see if we have an objective improvement in the measurements. And that was inspired by that prior study on inpatient discharge summaries, where they had good results from that.
And I know we're about a minute over, but I see Shake's got his hand up. Shake, do you have a quick question for us before we move on?
Well, I just want to make a comment that this is outstanding work by James, because if any of you that look at discharge summaries of our patients, you'll be bewildered by the immense amount of detail that are copied and pasted. And then if you start looking through the hospital record, you are even more bewildered by everything that happened. So any effort to simplify this, not only for the patients, but also for the physicians afterwards, has tremendous value. I think obviously this is in the earlier stages. As we go through more iterations and user data, this is going to get better and better. And I think James should be congratulated on this.
Yeah, mon congrats, James. Mon congrats. Thanks, Shake. Okay, well, in the interest of time, we're going to move on. Next up, we have Dr. Maggie McGrath, who's a bit of a UW lifer. She completed her medical school here and neurosurgery residency, and she'll soon head out to Barrow Institute for vascular fellowship, although, as I was joking with Maggie, I hope she doesn't catch on fire in that crazy Arizona heat. But today, she'll tell us about her research efforts in the use of artificial intelligence to predict outcomes and complications in patients with aneurysmal subarachnoid hemorrhage. Maggie, you are up.
Thank you, Dr. McDonald. So as Dr. McDonald mentioned, I'm going to be talking about a project that I've talked about in the past, I worked on during my research year, and provide some updates on the use of artificial intelligence in outcome and complication prediction for patients with aneurysmal subarachnoid hemorrhage. So I'll be brief with this because I know within this group we all know this, but aneurysmal subarachnoid hemorrhage is a significant worldwide health burden and also has a significant economic impact. For our institution, we keep patients in the ICU for 14 days to monitor and treat all of their complications, but most specifically what we're going to be looking at is shunt-dependent hydrocephalus and cerebral vasospasm. But we also know that that extended ICU stay has several negative sequelae, such as hospital-related comorbidities, complications, infections, delayed progression to rehab, and then increased cost of care. Prior studies have really attempted to predict risk, but they're limited in their univariate analysis, small sample size, and lack of time series data. Machine learning then has been really increasingly applied to help tackle some of those limitations because it has the ability to perform tasks that are not explicitly programmed, and so it can improve predictive capacity with time. So again, the goal of this project has been to not only predict those who are going to get cerebral vasospasm and hydrocephalus in order to preempt treatment and improve outcomes, but also to predict who is at low risk of getting either of these complications to hopefully help enable a fast track protocol to be able to get patients out of the ICU quicker. So we have a retrospective database of about 515 patients from Harborview Medical Center who were admitted with aneurysmal rupture across 5 years. We have 335 different quantitative metrics trended across their 14-day stay. And we use this data to train and test models for both spasm and shunt-dependent hydrocephalus. And I'll talk about both of the model creations separately. So for vasospasm, we use time series models incorporated into machine learning models. Each model used a patient representation from a prior time point to predict the likelihood of an event of vasospasm during subsequent time points. We have a Lindegaard, we have a logistic regression model that was trained using both clinical and radiographic data from the day of admission. So that's our baseline model. And then we also created one incorporating TCDs. Because of the small data set, or relatively small within machine learning, we constructed fixed duration time series segments by sampling a moving window across each of the patients. So for example, a patient whose spasm occurred on day 10, we would subsample using the 5-day windows prior, and each of those become extra data points. So it allows us to create multiple training instances on the same patient as opposed to just one training instance for one patient. The model predicted 3 outcomes: the likelihood of spasm in future window, the likelihood of spasm in the following 5 days, and the likelihood of spasm in the following 24 hours. And then we also evaluated neural networks, so long short-term memory models. We also evaluated feature influence specifically for TCDs using logistic regression models, so training them with and without TCDs to be able to help assess the influence of TCDs. The metrics that we analyzed were precision, recall, and then F1 score. So looking at some of our just baseline characteristics, overall, our vasospasm group is younger, more commonly tobacco users, and then more severe Hunt-Hess scores, Fisher scores, and overall worse GCS on presentation. For aneurysm characteristic comparison, those with spasm were more likely to have an anterior circulation aneurysm and then more likely to be surgically clipped over endovascular treatment. Here are just a few of our physiologic outcomes that we trended. Overall, there were not statistically significant differences, but overall there were higher velocities and higher Lindegaard ratios in our spasm group, and then higher MAPs and CPPs, which is likely iatrogenic. For our clinical outcomes, as expected, those with spasm have increased hospital and ICU length of stay, as well as worse MRS on follow-up. Of note, the mortality is actually lower in our no vasospasm group, but for this particular project, because we needed a certain amount of input to be able to make the algorithm work, to be able to put it in, we had to exclude those who died within 7 days. So I think the mortality of those with spasm is artificially low. Here's some of our time series versus outcomes. And so the dotted line is day of spasm. So we made that our kind of day 0, just to help visualize trends. And you can see spikes in some of our data inputs prior to the day of event. And so like there's a spike in nearly all of the TCD values, especially the MCAs. And then there's a dip in sodium before spasm, which we often see clinically. And then right following spasm, there's a peak in MAPS and CPP, which again is likely iatrogenic. Really briefly, this is just trending our baseline logistic regression model over time. So looking at the accuracy, the macro and micro F1, and you can just see that the slope is uptrending. So essentially, as we put more data in to the algorithm, it gets more and more accurate. Also saying that it gets more and more accurate closer to the event. So again, we trained those 3 models: logistic regression baseline, logistic regression using TCDs, and then long short-term memory. On the left here, we have the model's ability to predict cerebral vasospasm at any time point. And on the right, we have its ability within 5 days. Ultimately, we are hoping to get within 24 hours, but right now it's just not accurate enough. And I think that the take home from this is that the logistic regression baseline has the highest recall, and the long short-term memory model has the highest precision. So essentially, that long short-term memory model with the highest precision is the best for early identification of patients who may have vasospasm, but suboptimal for identifying those at low risk, whereas the baseline logistic regression model is best for identifying patients at low risk. And so really we'd have kind of separate models for, preempting treatment and for finding those patients who we can fast track. Looking at shunt dependency, so again, we use that same retrospective database. The model creation was slightly different just because we are looking at a binary outcome as opposed to trying to predict something that's going to happen on an unknown date. For our demographics, there weren't large variations in the group. Overall, those with shunt dependency had higher ASA scores, Hun-Hess scores, Fisher scores, and presenting GCS scores. And then here's just some of our time series data mapped against outcome. Overall, patients who were shunted had higher CPPs, MAPs, TCDs. And then this is where we're at with our current model prediction. So we're in the early stages of trying to optimize this, but thus far what we see, so orange is those who got a shunt, blue is those who did not get a shunt. And what we can see is that it's kind of a binary group, or bimodal group. So we have a subset of patients who we can very accurately predict that they're going to get a shunt, and a subset who we cannot. And so our goal from here on out is that we're going to try and use a rank threshold to try to really just look at those who are in the top percentage, so those that we can really accurately predict who is going to get a shunt, so that we can figure out what clinical features correlate within that group, with the ultimate goal of having a scoring system. So if patient meets X score, then we can say with 90% accuracy that they are going to need a shunt. And those who don't fall within the high enough test score, we just won't be able to apply it. So we're still working on internal validation. We switched over from ORCA to EPIC. So we are working on kind of our next data set for an internal validation set that would be prospective to our current data set, and then we'd move into the prospective single institution trial. Ultimately, the goal is to have a deliverable, so something we can incorporate into the EMR that can give us a like daily risk assessment for both of our outcomes. I would like to thank Dr. Ellenbogen. Dr. Shaker and Dr. Levitt have been my mentors with this project and have been instrumental in helping support me. Dr. Wang, who is our bioinformatics specialist, and then there's a number of residents who have been very, very helpful on this project. So thank you to everybody.
Excellent work, Maggie. All right, we see a couple hands up. Randy, you want to start us off?
Just real quickly, although you said that you were disappointed that you weren't able to develop a predictive model for those at low risk of vasospasm, you still did a predictive model of high risk. So it could be possible in that case just to stratify care to the high risk stay with their current pathway. The low risk actually get mobilized for rehab, et cetera, with the added training of close observation, like guidance as to what to look for if they need to be switched group to group. So I think you have actually defined a very useful group that could have clinical implications, no?
Yeah, I think so. And I actually think as we get more and more data, our accuracy in predicting those who are at low risk, I think that will get higher and higher. Right now it's at like 0.67, so it's not clinically applicable yet, but I do think we have the ability to improve it. But like you said, yeah, I think we can daily risk assess and change patients' groups depending on where they're at.
Yeah, as long as you're sensitive to ones you missed, so to speak.
Yeah.
And Shake, a quick question or comment?
Yeah. Yes. So the object of this research is twofold. The initial one is obviously prediction, but prediction on a day-to-day basis. When you see the patient with subarachnoid hemorrhage in the ICU post-treatment, what are the issues that the clinician should be thinking about? And so to act as a guide, so to speak, to that clinician, these are the problems that the patient may experience. And this is more pertinent in institutions where not many patients are being treated. Number two is the utilization of resources. So if you find patients who have low probability for vasospasm, they could be moved out of the ICU quickly. The last point is all AI models are dependent on two things. One is the accuracy of incoming data, and the second are the numbers. And of course, this is being the retrospective study, initial study. There were a lot of issues with the accuracy. That's why the prospective study is planned. And in order to increase the numbers, we need actually a multi-institutional study. So that's sort of where we're applying for grants. Zach is continuing this work along with Dom Nistall, and hopefully more information will be forthcoming.
Thanks for the comments. That sounds great. Yeah, no, it's really important work. And again, like Julian, Maggie's done some foundational work here and a lot to build upon from here to make it better. Okay, I think in the interest of time, we're going to move on to the next speaker. Next up is Dr. Nick Hug. Nick comes to us from Stanford, like James had. I guess traded sunny California for the liquid sunshine of the Pacific Northwest. That's all I got at 8:19 in the morning. Nick will be speaking to us on work he has done looking at predictive factors for the development of subdural hygroma hematoma in TBI patients over the age of 65, an important subpopulation of TBI by age that is growing these days. Nick, floor is yours.
Thank you. All right, good morning. I'm Nick Hug. I'm one of the second-year residents. And today I'm going to talk about some of the research I'm starting to do with Dr. Wiseman and the trauma group on looking at subdural hygroma formation in TBI patients over 65. I wanted to start just looking at a case example of a patient in this population, a 68-year-old male who presented after a mechanical ground level fall. He was found to have a little bit of traumatic subarachnoid hemorrhage in the right frontal lobe, as well as what appears to be a left-sided chronic subdural hematoma. He had a small occipital bone fracture that was non-displaced and was ultimately neurologically intact, other than some generalized TBI symptoms, and was admitted for concussion monitoring and ultimately discharged a few days later back to home with home health. At his 4-week follow-up in trauma clinic, he was found to have bilateral subdural collections concerning for hygroma versus hematoma. At the time, he was neurologically intact with very few symptoms and was ultimately discharged with a plan to follow up in 4 weeks with another scan. At that follow-up, he had acute blood in those collections, was starting to have worsening TBI symptoms, brain fog, gait instability, confusion, and was ultimately admitted for burr holes. And he had the burr holes here on the left side. This is a scan showing his post-op scan. You can see good evacuation of the subdural with some expected pneumocephalus on that left side. He remained neurologically intact and in the same hospitalization, underwent bilateral MMA embolization for management of chronic subdurals. At his 3-month follow-up, which was the last time we saw him in clinic, he had complete resolution bilaterally of the subdurals. He was still having some mild TBI symptoms, just a little bit of brain fog and confusion, and was referred to TBI clinic and has been doing well since then per the chart. So just as a bit of background, subdural hygromas overall have an incidence of about 3 to 22% in TBI patients. So they're generally asymptomatic, other than maybe some mild symptoms of confusion and brain fog. They're thought to arise from disruptions of the arachnoid in the initial trauma that lead to altered CSF dynamics, specifically allowing for a one-way valve where CSF can accumulate in the subdural space, but not be reabsorbed well. Blood can also cause adhesions and fibrosis, inhibiting CSF resorption. And these are importantly space-filling lesions, not mass lesions, which is thought to contribute to the lack of symptoms in these patients. They tend to be associated with compressible brains, such as in infants, or in atrophied brains, such as those with DAI or the elderly. And they do appear to be a mix of serum and CSF, not just one or the other, and have higher protein content when tapped. They're known to convert to hematomas, either chronic or acute. The incidence is, depending on what study you're looking at in the literature, ranges from 4 to 58% of post-traumatic brain injury patients. A few different possible mechanisms for this conversion, one being that these trauma to the duroarachnoid border causes a neomembrane formation with new vasculature, which can rupture and cause bleeding into the space. There's also thought to be some increased fibrinolysis in the hygroma, and increase in circulation of inflammatory molecules post-trauma can lead to leaky capillaries. Notably, while we don't have a great sense of the actual incidence, there does appear to be consistently seen an increased rate of conversion to hematomas in patient population greater than 60, potentially around 15% in one meta-analysis. So this leads to our question for this project. What are the predictive factors for development of subdural hygromas and conversion to hematoma in patients who underwent TBI over the age of 65? And the thought process behind looking at this is a few things that would be helpful for us as providers who manage TBI. First, are we able to identify patients early on who will need closer follow-up, even if there's resolution of the presenting injuries? For example, there are patients who have very mild traumatic subarachnoid hemorrhage who will show up in the ED that we'll discharge with no follow-up in our clinic. But are there factors that would actually prompt us to have them follow up despite the small volume bleed? Are there medications we shouldn't be prescribing patients? So someone who has a biffle injury as part of their initial trauma, should we be holding off? Should we be having a risk-benefit analysis of holding off on aspirin due to the risk of acute subdural down the line? And then are there any types of initial injuries that have a higher association with these? So maybe high-speed MVCs versus mechanical ground level falls. We have a pretty preliminary data set so far, just 20 patients we've identified in clinic as we've started collecting this over the past couple of months. But here's some initial data, no statistical analysis or anything, just kind of some big picture numbers. Of the 20 patients that met the criteria of being over 65, having some kind of TBI and presenting to clinic, 12 developed a subdural collection at one of their follow-up visits that wasn't there prior. 8 did not. The presenting pathology was kind of all over the place. These are not per patient, but total with patients who had mixed pathologies. Maybe the subdural collection, there's a slightly lack of subdural collections increase in someone who has subdural hematoma, which seems a bit counterintuitive, and this is just very underpowered. Mean age, maybe slightly younger on the subdural collection side. And then just looking at the subdural specifically, the average weeks to diagnosis was 4.5 weeks. 8 of the 12 patients were symptomatic. 2 ultimately underwent surgery. 3 underwent MMA embolization, and both the patients who underwent surgery also had MMA embos. So this is very preliminary data and very much still in process. Things that we're going to look at based on kind of looking through the literature on people who've done similar types of studies or looked at similar pathologies, sex, various comorbidities, the presence of a statin pre-injury or not in their MAR, the mechanism of injury as previously discussed, making sure we track GCS on admission and follow-up, and in these patients who are not patients who underwent surgery, did they receive an ICP monitor, and if so, what were their ICPs? And then more details about the injuries, not just subarach versus subdural, but laterality, location, if there's any midline shift, hematoma volume for someone who had a subdural. And then brain atrophy, trying to potentially do some volumetric measurements of patients and their brain volume if we have scans that can allow us to do that. And that's really all I have so far for this project. I'd like to acknowledge Dr. Wiseman, who's been the main driver for the project, as well as the rest of the trauma team here at Harborview, Dr. Bono, Dr. Buckley, Dr. Robin Pay, Dr. Chestnut, of course, and Dr. Ellen Bogan and Dr. Steege as well. And happy to take any questions.
Awesome work, Dick. That's fantastic. I know we're a little bit short on time. Any quick questions from the crowd? If not, I'll put a plug. As Andrew said earlier, we do a lot of quantitative volumetric work for a lot of clinical scans. And even if you have just a CT scan, we can actually get you a high resolution MP RAGE out of that and get you some of that curious volumetric data you're interested in. Because yeah, that patient looked like they had some considerable hippocampal atrophy, which makes me wonder about some MCI or potential dementia brewing underneath the surface, which can make it challenging to assess these folks post-TBI. So just a plug for if you need some help on that front. But excellent work. And I think in the interest of time, we will move on. So we'll move on to our next speaker. Our next speaker is Dr. Christine Park. Christine has come Duke University, where she not only completed medical school, but a master's degree in engineering focused on artificial intelligence. So really an interesting focus area. And I see Dr. Robin Payson and Ali can speak as well to the interest in our department of trying to grow some of the AI and QI work. So Christine today will be presenting on work she did defining the clinical intracranial hypertensive episode, or cliche. So Christine, do you want to take it away?
Sure, let me turn my audio. Okay. Hi, thank you for the introduction. Oops. Yeah, so as Dr. McDonald explained, I'll be talking about the clinical intracranial hypertensive episode, aka cliche, that I worked with Dr. Chestnut, Bono, and Nancy and Jason over the past year. The learning objectives for this presentation is, I'll go through all of this as my presentation goes on, but the goals are, one, to evaluate the reliability of bedside clinician cliches in TBI patients by comparing the clinician ICP data with the electronic data that were available in the BOOST prospective trial, and to analyze the discrepancy between the idealized and non-idealized cliches by assessing how often the electronically confirmed ICP elevations align with the clinician detected episodes and the implication for clinical management. And then three, propose improvements in intracranial hypertension monitoring by discussing the need for real-time electronic cliche detection methods to enhance accuracy in treatment and research. And so for introduction, we define cliche as something that we encounter every day during our care of TBI patients. And so it's when the bedside clinicians kind of identify when a patient is having intracranial hypertension episodes, and kind of note that and initiate treatments based on the protocol that they are given. And so, and it's fundamental to avoiding any kind of secondary injury to TBI patients. And we believe that accurate identification of physiology and meaningful events is the key to this, and it drives diagnostic and management decisions in taking care of these intracranial hypertension episodes in TBI patients, and hence influences the post-PBI course of these patients. Currently, the identification concerning cliches rests on clinical recognition by the bedside clinician, so most likely nurses who are taking care of the patients, who interprets the displayed ICV values on the monitor based on some kind of analytic protocol. And cliche identification has been defined in various duration and magnitude terms, but there has been little investigation as to how accurate and reliable the cliche recognition is by the nurse or the bedside clinician. And so there has been an increasing use of electronic physiologic data recording during the clinical management of these intracranial hypertensive episodes. And it's been useful to kind of correlate the electronic data with the bedside clinician interpretation of the ICPs, and kind of see what the differences and similarities are, and if there are any discrepancies between those two measurements. And so we utilized the data from the BOOST 2 trial to investigate this variation between the clinical and electronic identification of the intracranial hypertension episodes, and how the management of cliches kind of happen. In terms of some definitions, so we identified the bedside clinician ICP-5 as the ICP recorded by the bedside clinician during the 5-minute period that defines the cliche period, which we define as the time period that the ICP hypertensions were treated in the next 60 minutes following that identification period of 5 minutes. And the eICP-5 is the electronic record of the ICP during the 5 minutes. The eICP average is the average ICP value during the entire duration of the cliche. And then the eICP max is the maximum ICP, so a little different than the average. And then the idealized cliches were where the bedside clinician ICP measured during the first 5 minutes and the electronic ICP measurements during the first 5 minutes were both greater than or equal to 20 millimers mercury. And then the non-idealized was when there was discrepancy. So when the bedside clinician said the ICP during the 5 minutes was greater than or equal to 20, whereas like the electronic ICP record was less than 20. And the method that we used was we used the BOOST phase 2 randomized control trial data to gather the information about the bedside clinician ICP data as well as the electronic ICP data. And in terms of our protocol, we used the patient data in terms of when the ICP was greater than or equal to 20 millimeters of mercury greater than 5 minutes, and then who received some kind of a tier 1 treatment. And it was like an isolated intracranial hypertension episodes that weren't related to like a iatrogenic causes or maneuvers related to that. And then the goal was to compare the bedside clinician defined cliches against the electronic ICP measurements. And so, as I said, these were the this is a really helpful diagram that we drew out that kind of explains our protocol in terms of our patient population. And so in terms of our results, so this is the results for all of the cliches that we identified. The total episodes that we identified were 509 that satisfied our criteria. And this result is interesting because as you can see here, this is the bedside clinician ICP that was measured within the first 5 minutes and the electronic. So this is when the bedside clinician thought that the ICP was greater than 20, but the actual electronic record was less than that. This is when the average electronic ICP matched the electronic ICP max, which is accurate. But then when we look at the bedside clinician ICP data that were defined by 5 minutes, and then the actual electronic ICP for average and max, there's some discrepancy here in terms of when they thought the average or when the bedside clinician noticed that the ICP was greater than 20, the average was actually less than that. And that didn't necessarily correlate with the ICP max that they have identified. And so they probably thought that the max ICP for that period was, or the ICP that they measured at that time was the maximum rather than the average. And that was an interesting finding that we found regarding to the all the episodes for the cliches. And then when we identify, or when we kind of stratified the cliches into the idealized cliches, where we defined both the bedside clinician ICP-5 and the electronic ICP-5 greater than or equal to 20 millimeters mercury, we found also that there were, so this is, this matches in terms of the data that this is like a true cliche. But then there's also some episodes where there were less, the ICP average was less than the, for this data, there were some cases where the ICP average was greater than 20, and also the ICP max was also greater than 20, but then that didn't necessarily correlate with what the bedside clinician noted at ICP-5. And so even in the idealized cliches, there are some instances where there is a potential that the bedside clinician misinterpreted a high maximum ICP value as the general ICP average value, and so hence led to potential overtreatment of this patient population. And then when we looked at the non-idealized cliches, when we kind of try to see the bedside clinician ICP during the first 5 minutes greater than 20, but then the electronic record was actually less than 20. The most interesting data from this collection of data set is that there could be an overestimation in terms of when the bedside clinician thought that there was a ICP episode greater than 20, but then the actual average ICP, the electronic ICP average during that time was less than 20. And they could have mistaken that as like the max ICP. And so then it led to overtreatment, which could cause potential dangerous side effects for the patients during that time. And so in terms of the implications for this study, the clinical identification of cliches is not sufficiently accurate to guide treatment or research, and there could be some discrepancy that could lead to faulty data or faulty methods, and due to the incorrect ICP measurements that were noted during the actual clinical evaluation of the patient, that if there is no electronic data to support that. And so this kind of suggests that there is a need to develop a uniformly accepted algorithm for real-time kind of monitoring of the intracranial or intracranial pressures to kind of identify these kind of hypertensive episodes to guide treatments in patients in this population. And so then for future studies, there is a need to kind of reconsider the fundamental aspects of the methods that go into interpreting and responding to these kind of cliches that guide the overall TBI management for these patients. And so some limitations of this study include the lack of rigid bedside clinician ICP-based end of cliche definition. So we didn't have a definitive time when the ICP was less than 20, because there is always like a tail of fluctuation at the end of treatments for high ICPs, as we all know. And so there could be kind of fluctuations and ambiguity related to when that crisis time period ends. And then there's also some artifacts that are present in the electronic data that could be kind of confounding our results currently, as you can see in the charts. I want to thank Dr. Chesna and Dr. Bono for their mentorship, as well as Nancy and Jason for their overall expertise and statistical support in this project. We submit the first paper to critical care medicine, and the second paper is coming forth for another submission. That's it.
All right, great work. Any questions for Christine? Not seeing any hands raised. I think my one question to you is, have you thought about before, obviously it's going to take time to kind of technically develop the algorithm you're describing. In light of what you know, have you thought about essentially educational materials or resources to communicate to bedside staff in a way that will more align with what you've learned to help them get that accuracy, translation, assist them in doing some of the math that they need to do versus, looking at max versus average?
Yeah, so I think we still have a lot to work on in terms of how we can best treat this issue. And a lot of it comes down to, as you said, the education for the bedside clinicians who's taking care of these patients. I think the key is, so we do have a protocolized kind of method in taking care of it. So we use the BOOST protocol here at UW, but so we are looking into a lot of the data on how effective the treatments are for taking care of these patients. And we realize that, there's a lot of sequences of events that happen, but we don't really know if they're actually being effective in terms of treating the hypertensive crisis. And I think Dr. Chesna mentioned during his talk that there's two kinds of approaches that you could use. There's like a crisis approach, where if we see a spike in the ICP, we can kind of do aggressive measures to lower as much as possible. And then there's like the tranquility method, where we don't really have an ICP monitor, and we kind of like give a scheduled dose of medication to lower the ICP in case that we suspect an ICP crisis to happen. So I think there has to be a lot of research that has to be done more in order to kind of figure out the best way to educate the clinicians at bedside, because I don't think there is a good way, unless because a protocol is useful because we can tell all the individuals that, oh, this is what we do, and it's a systematic method of kind of trying to resolve this problem. But as you can see, it doesn't necessarily work that well in all cases. It doesn't apply to all cases, because all kind of intracranial hypertensive episodes are unique. And so I think a lot more thinking has to go into it. And I think the electronic physicality recording of the ICP is useful. And I think that's one step. And having that real-time kind of measurement is one step to achieving that goal.
Good. I see we have a hand up. Wow, Eliza, you have changed considerably. Adriel, questions to Christine.
Thanks for the talk, Christine. I was wondering if in this data set you have information about patient outcomes, because I think one of the questions I think to answer that comes from this is, when clinicians are treating the bedside spike, even if it is an overestimation of the average ICP that we're getting from the electronic data, is that bad? Does it lead to better outcomes? Because I think it could potentially be useful in terms of answering some of that question of crisis method treatment. You know, if there's a discrepancy is one thing, but I don't know if we can call it over treatment per se, because we don't know, you know, if that bedside evaluation of the spike in that moment is actually the thing we should be treating for improving outcomes or the opposite. I was just wondering if that data.
Yeah, I definitely agree. Yeah, there were a lot of discrepancies. When I say over treatment, I mean like if there were episodes where we did identify or the bedside clinician did identify a elevated hypertensive crisis, whereas the actual electronic record didn't really reflect that. I think so. We'll have to look into the boost data set a little bit more in terms of whether or not we actually have outcomes data to look into whether or not there's actually implications when we treat these patients. When the bedside clinician's interpretation of the ICP there's a discrepancy between that and the electronic record. Yeah. And so I would have to kind of talk, with.
I don't know if Randy wants to comment on that. I do see his hand popped up. I know he knows that data set better. Randy, did you want to comment on that?
Yeah, real briefly, I think what we've found is that we can't really trust anybody at the bedside, nurse, doctor, fellow, whatever, to be a running real-time mathematical integrator while they're doing their other work, etc. I mean, I just think it was unrealistic, and we've now shown that what we thought we were getting is not what we were getting. The trouble is that, I mean, this reflects what we've been doing up to now, and that doesn't invalidate anything. But for the future, we need to define what we're studying in order to understand it. And that means probably an electronically defined real-time display of what we want to call intracranial hypertensive episodes. And that will take probably a consensus conference to develop like an IEEE definition. And that's actually what I'd like to convene is another CYBIC type conference to come up with an acceptable definition that we can then hand to industry and have them integrate into our machines.
Yeah, no, I think you're spot on. And a work that folks like Christine, with her experience in artificial intelligence, could probably, once you have those guidelines, take and develop into an app. So some nice complementary skill sets there. I know we're a couple minutes behind, so I'm going to move us on to our last speaker. Last but never least is Dr. Zirun Zhao. Dr. Zhao has come to us from Stony Brook University Medical School and Duke, where she did her undergrad in neuroscience. And she'll be presenting today on her work entitled Reduction in Surgical Site Infection of Baclofen Pump with Antibiotic-Eluting Envelope Implantation. Zirun, you ready?
Yep. Thank you.
All right.
Great. Thank you, Dr. McDonald. Today I'll be talking about a antibiotic-eluting absorbable envelope at the time of implant for intrathecal baclofen pump in the attempt to reduce the rate of surgical site infection. And this is a deck of slides that is adapted from Dr. Recker and a team led by Dr. Brown and Dr. Buckley. Some background for this study. Spasticity affects more than 300,000 children in the United States, and most common causes are cerebral palsy, TBI, SCI, anoxic brain injury, and other types of brain malformation. Over time, spasticity can lead to contractures, joint deformities, scoliosis, and a lot of other secondary impairments that really limit the children's quality of life. Therapeutic options are a few, and they range from least invasive to more invasive, starting with bracing and physical therapy that help with the weak muscles to augment them with bracing, to injecting Botox into affected muscles and trying to relax them in that way to reduce spasticity, although the time frame for that is limited to usually 4 to 6 months. Other types of oral medications can also be very helpful. Most utilized will be PO baclofen, diazepam, and other medications over feeding tube or orally. And then baclofen pump with intrathecal delivery if they are proven to be beneficial from the ITB trial. Other surgeries could also be helpful for from orthopedic side, and also we also do selective dorsal rhizotomy for those that are selected to be beneficial. Today's talk will be mostly focused on intrathecal baclofen pump, which has shown to be effective and improves quality of life in patients who otherwise have intractable spasticity. Although intrathecal baclofen pump has its own set of complications, which a lot of it include infection. Other complications include CSF leak, pump malformation, different types of catheter malfunction, including tear, obstruction, migration, and also medication withdrawal or overdose from pump malfunction. Overall complication rate is 3 to 40% in literature, and complication rates are proven to be higher in pediatric population than in adults, which I'll go into a little bit. And then the scope of this project is to investigate surgical site infection and ways to reduce it. It is also proven that it's higher, there's a higher rate of SSI in pediatric populations with various reasons that are hypothesized. There may be poor wound healing in children with severe spasticity. Higher percentage of G2 presence are associated with higher rate of infection. Prior revisions and the number of surgeries that they previously had greatly increase their risk for surgical site infection. Also, children may have a higher rate of urinary and fecal incontinence in the cerebral palsy population. The rate of infections around to peak around age 4 to 6, and then risk factors, as I mentioned, G2, low BMI. Also, there's thought to be a subcutaneous implant versus subfascial implant for large pump, and especially for low BMI kids may make a difference, and the number of prior revisions. Impact of surgical site infection will, include additional surgery, additional hospitalization, and ultimately affecting their quality of life. So some studies have looked into standardized protocol that has been shown to reduce the rate of surgical site infection. This study at Texas Children's Hospital looked into a standardized protocol with preoperative cleaning and prepping, antibiotic regimen, and also a few steps in surgery, including irrigation and some iodine-wrapped catheter and pump that in their study reduced the rate of complication, although not significant in the rate of infection. And at Seattle Children's, we have a protocol for all of the baclofen pump or replacement cases where we routinely do pre-op IV antibiotics, routine chlorhexidine scrub, alcohol wash, and then chloroprep, ioban, limiting personnel scrubbed, and water-based scrubbed only, double gloving with changing the outer gloves, antibiotic irrigation, antibiotic injection into the pump. And then lastly is the antibiotic eluting absorbable envelope, which we started using since 2020. This is a figure for the envelope. It is this orange material, mesh material, that elutes antibiotic over 7 days. And it is FDA approved for implantable cardiac devices, and most of the previous study were focusing on cardiac devices, and the knitted mesh absorbs in about 9 weeks. Some of the prior studies, as I mentioned, are mostly in the cardiac implantable groups, and one of the major ones was published in the New England Journal of Medicine, where this is an industry-led study where they investigated a small group of use of envelope versus control, where there's shown to be an decrease in infection within 12 months. Although the p-value is 0.04, and there might be some difference in the baseline characteristic between the two groups. Nevertheless, there are several other studies that have shown that using the envelope may be beneficial in reducing complications and infection. So this is a diagram of the placement of the mesh, which in the pocket is the pump, and this device or this mesh is a little smaller than the pump size. So usually we cut them in half and then put each piece on either side of the pump at the end of the baclofen pump replacement or placement. And then really our question for the study is whether using this reduces infection rate. We looked at cases that happened between September of 2017 to April of 2024, where after 2020, the use of the antibiotic encoded envelope became routine, and then dichotomized into groups with use or without use of the envelope. And then the primary endpoint was to look at surgical site infection. Secondary endpoints was pump explantation and other types of complications. Going into results, so overall there are 144 patients that we identified. 43 did not have the use of envelope, and 101 patients had the implant of envelope. Overall, there is no difference or significant difference in their sex, their age at the surgery, which roughly is about 10 to 11 years old, or their G-tube status, significant comorbidities, and prior MDRO infection, which all of these can have an impact on their rate of infection. Other baseline characteristics include etiology of spasticity or their gross motor function score, which are also comparable between the two groups. And the length of follow-up in the no envelope group is slightly or significantly higher just because they are a period of time that is further away from the time point of our follow-up and outcome. And going into the rate of surgical site infection and explant, overall, there are 4 total pump site infection in the no envelope group and 0 in the use of envelope. And in terms of post-op pump explantation, there is 5 for the no envelope group and 2 in the envelope group. The 2 in the envelope group that required explantation are pain-related, and also there was 1 where they eventually needed selective dorsal rhizotomy, and ITB was not found to be helpful anymore. So though the 2 explants were not related to the to any infection in the group with the use of envelope. And there is no major safety concerns or complications that were related to the envelope in our 4 years of retrospective study. So I think overall, there is not really a significant difference in the total pump site infection, but in the pump explantation, there is a difference, although, all of this is limited by the smaller sample size. But I think right now the preliminary conclusion that we can get from the study is implantation of the antibiotic-eluting envelope is safe and reduces risk of surgical site infection. Going to limitations, this is a single institution study, retrospective with a relatively small sample size. And currently we are obtaining the length of stay data and trying to pull data into looking at the cost of hospitalization to try to see if the reduction in the cost of hospitalization justifies the use and the cost of the envelope. So that's currently what we're working on. At the end, wanted to thank Dr. Brow, Dr. Buckley, Dr. Ecker, and also James and Erin from the children's side that have contributed to the study. And thank you for including me in this study. These are the references.
All right, excellent work. Well, as we strive to give our last speaker as much attention and support as our first speaker, any questions, comments from the crowd before we conclude for today? All right,
Zirun, can you hear
Dr.
me?
Chestnut. Oh, and Bono. All right, Rob, do you have a question? Oh, I see Randy's hands up too.
Yeah, you can go first. That's fine.
Well, I just had a quick question in terms of the possible confounding of the institution of the protocol and beginning to use the antibiotic sleeve. Because everybody tends to pick up new bright shiny objects. When is the data from non-sleeved patients older, and is it before the use of the general protocol, which could have a confounding effect?
They are older because since 2020, we started to standardize the protocol, and with the envelopes implantation. I do not know at the top of my head whether prior to 2020 we have the same standardized protocol in terms of, you know, all the scrubbing and the antibiotics and other aspects of pre-ops that we do. So that's a good point. We'll definitely look into it.
Yeah, and Rob?
Yeah, I was just going to say, you know, assuming the data are, you know, bear out, it's very impressive in terms of the infection reduction rate. Certainly see some other applications in neurosurgery where it could be helpful in cases where we're putting big things in and have high infection rates, such as cranioplasty, shunts, et cetera. So just encourage you to consider looking at this in other procedures as well. I think it's a great idea.
Definitely.
Always something new to learn and investigate. Well, thank you to all of our excellent speakers. Thank you to everybody who has participated and listened in today. It's always so motivating and inspiring to hear the work that the residents are doing, not only as they hone their surgical skills, but also their research and clinician scientist skills as well. I'll turn it over to the boss. Any last comments? Otherwise, I think we might be done.
Fabulous work. Thank you to all the residents who are doing clinical and research and educating the next generation all at the same time. Amazing. You are the future. Thank you so much. Thank you. Have a great week, everybody.
Thank you.